Welcome to the OrthoJOE Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swiontkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo, and Happy New Year. We've had a bit of a break here on OrthoJOE over the holidays, and we're now getting back into it. And as I was reading, I don't know whether it was the last edition of Ortho Evidence or the one before, but you had a very stimulating piece on the role of sham surgery. And so it got me to thinking, as the editor, have we published many manuscripts on surgical techniques or interventional procedures with sham controls? And I had a good hard look using our search engine and didn't find very much. We have had 4 editorials on the ethics of sham surgery, one of which you actually authored, I think it was in 2007. So there are really major ethical questions in regards to using this type of control in procedural analysis. So can you just let me know what your thoughts are on the use of sham as it stands today?
Yeah, you know what? And also Happy New Year, and let's hope that 2021 allows us to move forward in more ways than one. I do hope we'll get a chance to travel a bit and interact face to face. But until that time, we're going to continue with these sorts of discussions. You know, that the issue on sham surgery kind of comes up every couple of years. And thanks for noticing that one OE original that we did. And, you know, we sort of said there are 3 things that I think most people should remember about sham surgery. And we looked around very carefully this was one of our December issue. But that being said, you know, the first thing is just making sure we're all agreeing on what we're calling sham. So you're using the term sham. And, you know, in a way that I think of it as, you know, the drug equivalent of a placebo. So, you know, a procedure that is otherwise identical to everything else that would be done, except for what we believe to be the true therapeutic benefit. So, you know, I always go back to that single Journal of Bone and Joint Surgery trial by Bruce Moseley, you know, which was the first one, which was the sham arthroscopic debridement study for knee OA. And really, it was the actual debridement itself that did all of the effects. So therefore, everything but that would be, in theory, the sham, you know, in theory. So it's a very interesting challenge because you've got proponents on both sides of it. There are those who believe that, you know, the purist would also say, how do you tell whether a surgery truly works? Because patients put so much, you know, you can use the term faith in the belief that this procedure is helping them. And so there's been that debate back and forth around how do you truly find a control? So if it is not for a sham, then how do we actually limit, quote, bias, you know, the perception that a patient knows they've received something? And so we've struggled with that. As you know, the trials we've done together and the trials we see in orthopedics always are limited by that one potential factors that surgeons know what they are doing, and patients are aware of what they've received.
Right. Well, as you point out, Moseley with the VA and Houston study with an actual sham control for arthroscopic intervention with just the portals and no actual intervention was really the study that provoked this discussion in the orthopedic community. And if I'm not mistaken, there was a large Finnish study that basically repeated that in about 2013, 2014, which had the same basic result. And one of the things that is, I think, always, I guess, bothered those of us in academic publishing is that a patient that would sign up for a study like that, knowing that they're going to get an incision without any actual intervention, has got to be rather unique and not representative of the broad patient group. What are your thoughts about the differences in a patient that would sign up for such a trial?
You're right. I mean, you know what it goes back to? It goes back to 2 things. One is it goes back to the belief that a sham itself is doing nothing. But if you truly want to evaluate, quote, a placebo, a sugar pills effect, or a saline injection or a surgical incision effect, you've got to have a comparison that is a non-treatment comparison. And the problem is most of the trials will say active surgery versus sham, and they forget that third arm. The third arm would be a natural history or a non-treatment. The only way to know whether there truly is no impact of those two incisions was to find out if we did nothing and did that, there was no difference in outcome. But usually what you happen when you find out in every other area, especially in the world of oral placebos and injectables, for example, for let's say NEOA, when you have a no treatment and you put on top of that a saline injection that is considered a placebo, let's say, there is a pretty dramatic effect. In fact, that effect alone is one that would, in most cases, exceed what will be considered the minimal important difference for a particular outcome. So now you're in this quandary where people will say the opposite. They'll say, why give them a treatment? Just give them a saline injection. It works. And then the argument against that, to your point, is it only works if they actually think they're getting the real treatment. If they know they're knowingly, as you said, going to be getting a sham, it's not going to potentially have the same effect. So this is the challenge that this whole area, faces. So I think what's been happening, if you look at modern day attempts at this, you're looking at it not so much as an incision and walking away as it used to be, it seems. What you're seeing is the following. Let's say in a hip arthroscopy trial, we'll go in, we'll do the labral repair, we'll do the we'll do the bony work around the hip. And the opposite is we'll just go in and we'll do a diagnostic scope, we'll irrigate, and they sell it as it's not a sham, it's actually another therapy, but a therapy that all intents and purposes should have no impact if in fact the bony work and the labral work actually is effective. That shouldn't have the same impact. And so in fact, we've seen this trial just like that called the first, and in fact demonstrated at 1 year there's no difference, by doing just arthroscopic lavage, which in itself is being framed as a treatment.
Right. I did, in my review of the journal, what we published on placebo control, I did come across a couple of studies on vertebroplasty where the control was just simply not injecting the cement, but doing the same additional procedure. And I think that gets to one of the ethical issues that your article, as well as the other three discussed, is that we need to be responsible in trying to limit the risk to the patient and avoid at all costs of having it be no potential upside. So I think it does really limit the applicability of considering just making skin incisions and not providing some opportunity for benefit to the patient. Do you agree with that?
Yeah, I do. And I think if you look at why you would now try to do a procedure, it would be very hard to justify something that potentially has risk, has absolutely, hypothesized zero benefit, and quite frankly, is done in a way where the patient's informed consent may not be entirely informed. So you've got to have at least a minimum of telling patients up front, there is a chance that we will do the following. We believe the following may have no impact. But, in a weird way, when people get a saline pill, a saline placebo, I mean, for all intents and purposes, the belief is that it shouldn't harm you. We don't think it will. We anticipate it's going to have no effect. And we're telling you that you're going to get a placebo. And patients enroll in placebo-controlled trials all the time. I think, as you're arguing, the big difference is the risk profile is very different in taking a sugar pill than getting an incision. So I think the argument there really was going to be is how do you defend the risk profile? The funny thing, though, is if you look at placebo trials, a lot of the same complaints that they would get in the drug, they're getting in the placebo. I mean, they're getting the same sort of generic effects that you would get with taking, any sort of standard accepted, approved medication, which in and of itself just tells you the power of belief of I'm getting something.
GI symptoms and headache and whatnot.
Right.
Sugar pill.
Yeah.
It's a very interesting thing. Gets it really to the importance of the mental and psychological status of our patients and how we can impact that as practitioners. And I think it's a really a emerging area of musculoskeletal science of beginning to understand the patient's psychological background and what can influence it, and how we can favorably, create an environment where a patient can benefit from what we're recommending.
And you know, the paper that I recall that really did use the 3 arms and really did try to attempt it, was published in the Lancet, I don't know, maybe 3 years ago, was the work from our mutual colleagues at Oxford. So Andy Carr and Beard were involved in, I think it was a an arthroscopic subacromial decompression trial, where they did the actual surgery, they did some version of a sham where they did the incisions, and then they did a non-treatment arm. So they added that non-treatment arm.
Right.
And like all other procedures, they identified that there's no difference between doing, basically incisions and doing the full procedure itself. And a decompression is clearly there's a therapeutic, an implied therapeutic impact of doing that. And then they tested it against doing nothing. So doing either of those things versus nothing had an impact, which gets back to the fact there is a sham effect, even when you're doing, an incision, let's say, in the skin.
Right. But an effect that's heavily dependent, I think, on the interaction between the practitioner and the patient.
Yes.
And the information that's exchanged, and the kind of sensing the patient where they're coming from, and encouraging them to be open-minded as to the effect of this intervention, et cetera.
Yeah.
I think one of the things that many people consider as the gold standard is FDA approval for interventions, devices, et cetera. And we published a study a few years ago that looked at 49 studies involved in the FDA approval process from 2001 to 2015. And only 50% of those that resulted in approval of a device or intervention were double-blinded in the evaluation. The article was critical of the fact that in designing trials, we investigators are not optimizing double-blinded evaluation of outcomes, which you have written on in the past.
Oh, yeah.
We have published on in the past.
Right.
Of interest is, of these 49 studies, there was no sham controls in any of them that resulted in approval of the device or intervention. So although I think we understand the sham control is to be the highest level of elimination of bias, it's not, I don't think, ever going to be widely used in surgical intervention for ethical reasons, et cetera, and lack of generalizability, that a patient that would agree to potentially have an incision and nothing else is probably quite different than the general population.
And I would say exactly that. I would say, that from that perspective, you're absolutely right. So what do we do then, right? So in the absence of, so we say, okay, if you're going to do a sham controlled study, and truly sham, not sort of couched in, we have 2 treatments, one is lesser important, but a true sham, I think it would have to be, something that would be largely a very small study. And that gets into the challenges of, like, how are you going to do large generalizable studies that are going to have more external validity? And I think if you have the balance in par, you're right. I mean, you have to think, what are the other bias reducing measures that we use? And you kind of use the same things that we've always talked about, is if you can have a situation where the surgeon knows what he or she is doing, and the patient knows what's coming in, you've got to find a way that the outcome assessment somehow is independent of those 2 individuals in a way. And the more we do that, it makes it easier. It's hard when it's a functional outcome measure or patient outcome measure, because so much of it is entrenched in what they believe already internally, what they believe. So that's always a challenge. But I can tell you, in all our big trials, we've never really seen a big difference, implant A versus implant B in a functional measure. It's always been something that we believe is a bit more objective. And maybe that is because we're trying to limit some degree, some of that human, perception.
Sure. Well, you and I remain advocates of large, simple trials.
Yes.
I know we're open-minded to new ideas, but that one I think is pretty well entrenched in our minds. So
it is.
Yeah.
It's a big one. And the thing is, I don't think you could actually, I mean, you're right. I don't think you'd have a hard enough time just getting a large trial done, let alone trying to, convince people that they're to be getting a placebo. It's, again, I guess the big differentiator here is sham is perceived as placebo, but a placebo trial is on a different level of practicality higher than doing a sham surgery. That's the difference. I mean, surgery is a whole different complex of stuff. But no. And this debate will continue. So when it's funny that when we bring it up, there's lots of interest in the readership in trying to understand this, because I think there are groups that are really trying to push it, particularly, as you know, the group, that specific group, the Fidelity group, that was related to some of the knee work. They continue to do work in this area. And there's some groups like that. Oxford's obviously been able to do some work in this area. But I recall from hearing from some of those investigators, it was a very, very difficult trial to get buy-in and get people to do, but good to them to be successful in doing something.
Right. Well, we'll stick with large, simple trials and the advantage of generalizability. I think.
Hey, I'm with you. I think it's absolutely right. The more patients, the more generalizable.
Right.
The key, the thing that every, whether it's FDA or whether it's NIH or whether it's another big international, funder, I think at the end of the day, when you're talking about these sorts of trials and you're considering it, let's say, okay, I'm going to consider, I'd love, if it was possible to do this, that would be great. What will be the next best thing? Well, you can almost argue the next best thing is what's happening, right? That's what the FDA in many ways is accepting, which is a very clear, objective outcome that is measurable, a bias-limited way in which you measure that, ideally independent, and enough patients, enough sites, enough people bought in. That's it's still a pretty good approach, right?
We agree. So until next time, and maybe next time we'll have our coffee cups and we can say cheers at the end.
Oh, I had mine. Now, listen, I can't start the day without coffee.
Yeah.
So cheers.
Cheers. Till next time.
Till next time.